I think we are ready to go. Well, welcome everyone, and thank you for joining us today for this webinar on transforming patient care by leveraging AI to develop an evidence-based 360-degree patient profile. If you were expecting to be on another webinar, you are welcome to drop off unless you're really curious about this topic and you can stay on. I did want to start with a quick round of introductions. My name is Dennis Joseph. I'm the Senior Director of Healthcare Practice at Digital Scientists. Almost 25 years in healthcare. Most recently, I was leading digital health for the urology and critical care space for Becton Dickinson, but a long history of executing digital solutions and really baking digital solutions into clinician workflows, because we all know that until it's fully baked into the workflow, it's one more solution, which almost always is never used. And so we've been most recently executing a lot of work in value-based care, especially in skilled nursing facilities, and we'll talk a little bit about those learnings during this webinar. I'm also happy to say that I'm joined by my esteemed colleague and good friend, Greg. And Greg, I really don't want to botch your last name, so I'm not going to give it a shot. So I'll let you introduce yourself, including your last name. So over to you, Greg.
Pretty common. I'm Greg Zancewicz. I think you see the spelling in the Roman letters. There's also a Cyrillic version of it somewhere. I'm a senior developer with Digital Scientists. I'm a habitual technologist, dating from when I was a teenager. I've got, hate to admit it, probably close to 40 years of experience in a whole bunch of different tech fields, healthcare specifically over the last probably 15 years or so, and that's specifically in software. Other than that, I've been involved in defense electronics, telecom, semiconductors, robotics, and I've gone back and forth between technical fields and and uh, product management fields, which is a little unusual. I got bit by the ham radio bug when I was a teenager. I was supposed to be a veterinarian. I ended up going to MIT, and so I say my parents were the only parents I know who were disappointed their kid went to MIT because they wanted me to be a vet. But here I am and happy to be here today. My work at Digital Scientist centers primarily, it's almost exclusively on healthcare related applications.
Yeah, Greg, in terms of the total population of parents, that would be a very, very, very small subset of parents who would be disappointed that their kid went into MIT.
And I throw that out there, if you're from Georgia Tech or Caltech, you're probably not impressed. But, the thing is that MIT tries to maintain a quota of a certain number of kids from every state. And I was from Rhode Island. There were very
Ah,
few applicants that year. And so I kind of got in under the wire.
well,
So
although
me
I'm
too.
sure that there's quite a few
We're,
smart
we're
people from Rhode
impressed.
Island too.
And you were me too.
That's right. And of course, a reference to Georgia Tech, digital scientists, we are based in Atlanta, Georgia, and obviously quite a few of the team members are Georgia Tech grads, and so there's always this constant hustle between Georgia Tech and other technical um, universities. All right. In terms of the webinar, just some quick logistics. We'll be running for about 30 to 40 minutes or so with time at the end for questions. Please submit your questions through the chat. We'll address them during the Q&A. And if we run out of time, we will address them individually. The session is being recorded and the slides will be shared afterwards. So that said, without further ado, we do have a ton to share. So let's just jump right in, and I am going to share my screen. So let's jump into why are we doing this webinar. And this is a series of webinars started off talking about, and I'll do a quick recap, but we started talking about the MDS process that's executed that requires a CMS submission every quarter. But if you really were to step back, it's really about delivering high quality patient-centered care. And why we are doing this webinar is without fully knowing who your patients are and all of their conditions, it is literally impossible to deliver that high quality patient-centered care. And this is what this webinar is this is why we are presenting this webinar. It's kind of like solving a puzzle with half the missing pieces, right? But when you have the full picture and you have all of the pieces, you can put a care plan together that's really comprehensive and really drives outcomes. The other big piece is it also enables personalized interventions. Right? When you think about adjusting medications, when you think about preventing falls by putting programs in place, when you think about proactively calling on the patient, especially if they are a congestive heart failure patient and you want to prepare them as they go into the holiday season, it really helps clinicians or providers put those comprehensive plans together, and you're always 2 steps ahead. The other big piece and the reality of today's healthcare is teams are interdisciplinary. And so you have multiple teams focused on different aspects, and that requires collaboration. How many times have you been in meetings where there's a lot of he said, she said, because the records don't match and everybody has a different version of truth? And so by doing this 360-degree patient profile, no more he said, she said, it's we said. And it's all there in the record and it's evidence-based. And finally, you can get all of these multidisciplinary teams all on the same page. Now, by doing all of that, here's the kicker, which is the proactive risk identification. So, I live in analogies, and so the analogy to this is Netflix, right? We all like to binge watch shows on Netflix, and Netflix obviously has a series of algorithms in the background recommending shows to you based on your history and based on what you watched. Here's what's next. So imagine that for healthcare, which is the ability to proactively risk identify that patient and then proactively giving you recommendations of what you could potentially do to um, to take care of that patient and provide care in a timely manner. The other big piece is we know that patients travel, right? They don't stay in one site of care. There are transitions of care. And so think of it like a relay race where you're passing the baton. Only now that you don't have any cases of the baton being dropped or communication or miscommunication. And so as we think about a common record that is constantly updated and it is your source of truth, communication flows a lot more seamlessly. And the patient feels like they are the star because they are the center of that communication. So the reason why we're doing this webinar is because we've done this and we know it's hard to pull off. It requires a strong technical infrastructure, robust models, aggregations of many data sources, and we have many stories to share from that perspective. And you want all of that insights to be validated by the clinician, right? So it sounds impossible, but it is possible. We've done it, and we are here to share some of our bruises. I meant learnings. And Greg, you probably have way more bruises than I do as we go about putting this together.
I and my colleagues.
That's right. We share the bruises across the team, right? So just a quick blurb. I got to check the box off on who we are. So we are digital scientists. We are a technology strategy and delivery firm. We enable healthcare companies to operationalize AI inside of their organization. And what does operationalizing AI mean? So we don't look at AI as one product or one solution. We kind of see this as an end-to-end innovation, an ecosystem with technology, patients, and clinicians at the center of it. We also know that, and obviously AI is there's a lot of buzz around it, but there's also a lot of risk and complexity that comes with it. And we are a team that recognize that risk and complexity. And we want to take that on. We want to own that risk and complexity and help you solve that for your teams. And finally, it's all about outcomes, right? There's patient outcomes and there's business outcomes, and we want to stay accountable to those outcomes. And so a lot of our engagements in the past, we've made sure that not just that we've delivered the solution, but the clinical teams are executing on the solution, and they're actually able to see the rewards, whether it's from a clinical outcome perspective, whether it's from a revenue increase standpoint or a cost reduction standpoint. We want to make sure that those outcomes are realized and that you are successful in your venture. There's a lot on this slide. I'm not going to go through everything. As you think about a digital experience that you're trying to bake into the workflow of your teams, we know what it takes. We've been doing this for, I would say now 18 years across a variety of companies in healthcare. And, we're going to talk about some of these case studies, but as you think about some of the non-negotiables, like security and privacy is a non-negotiable. Making sure the solution is integrated with other systems like your EMR or your remote patient monitoring or your medication management system. That's a non-negotiable. The user experience has to be just right. And Greg will attest to this, which is some of our solutions are really largely invisible. There are algorithms running in the background, providing recommendations in a pop-up inside of an EMR, right? And so what we've built sort of stays behind the scenes, because the ideal user experience is not to introduce one more product or one more solution to this. And of course, having a solid platform that you can scale and build a roadmap around is something that's important. So again, a lot of stories coming out of almost 18 years of execution, and the clients that you see on here is just a subset. Just a quick blurb on the agenda. We have quite a few to cover. I'll do a quick recap from our opening webinar. And yes, we've been using the word Patient 360, and some of you have been curious what that means. So we'll uncover what Patient 360 really is. We'll talk a little bit about the complexities. And here I may be preaching to the choir because you all are on the front lines of managing these patients. We'll take a high-level approach in terms of how AI is transforming patient care, with specifically around the ability to put this unified view of a patient together. And then we'll get into the next level of detail, which is what does it actually take to build this 360-degree patient profile? We'll talk about a case study really quick and some of our learnings, and then we go into Q&A. All right. So our webinar was about a month and a half back, I believe. And so the webinar was really an opening take on, specifically on MDS, the MDS assessments that are done on a quarterly basis and how AI is enabling timely and accurate execution of MDS. Obviously, MDS is think of it like taxes, right? They need to be accurate and they need to be filed timely. And you want to make sure that you're taking advantage of all of the withholdings and all of the benefits that come based on your situation. MDS is pretty much like that. So as you think about accurate, timely assessments, they're important not just for care planning, but they're also critical for quality measures. They're critical for reimbursement under the PDPM model. And of course, compliance is non-negotiable. So we talked a lot about how AI is turning out to be a little bit of a hero here in terms of turbocharging that process. And how is it doing that? It automates data collection, it boosts accuracy. Obviously, compliance is front and center. And it does that by analyzing data faster and also making sure that the clinical teams are efficient with their paperwork and really focus more on patient care as against paperwork. Overall, it makes care better. It keeps quality penalties in check. It helps you get reimbursed appropriately for the care that you're providing. Obviously, all along, it covers insights that makes patient outcomes sparkle because you don't have any oops moments in terms of coding or clinical assessments. Finally, obviously, here's the catch. AI has got to play nice with your EMR or EHR or any other system that you're tightly integrated with. And so that integration piece is critical to turbocharging your workflow. You don't want to manually replicate some of the work from one system to another. And the other big piece is how do you empower your organizations to go after this? And we talked a little bit about a how-to in terms of putting pilot programs together, having a solid training regimen for your staff, but really empowering your MDS coordinators and nurses with the right tools and skills, and really watch AI transform that MDS process, which is quite laborious today. And I talk to a lot of MDS nurses and coordinators, and it is very one laborious, and the other is it really is dependent on how much experience an MDS nurse has. And obviously, the more experience you have, the better you get at that process. But there's a lot of new nurses coming into the profession, and how do you get them up to speed? And having a good technology that assists them with this process really helps. All right, so let's finally get into this webinar topic, and let's start with patient 360. So when we say patient 360, what we really mean is a comprehensive, unified, holistic view of a patient's health information and history. It's commonly implemented through technology systems like EMRs, EHRs, analytics platforms attempts to put that picture together, and some of the integrated care solutions attempts to put that information together. But there is a ton that goes into a patient 360. One is obviously the consolidated data. And this is taking information from everywhere, like your clinical records, your billing records, even your social factors like housing or access to care or even income levels based on the county that you're living in. It merges all of that into sort of this powerhouse of information that you can dig into in terms of some of the causative aspects of certain conditions. So that's sort of this point in time, right? But there's also this longitudinal view of that patient record, right? It's not just a snapshot, but you want to see how the patient's progressed. It's just showing just historically the diagnosis, treatments, outcomes over time, complications, transitions of care, etc. So you want to make sure that you have that historical longitudinal view of the patient. Finally, this information just sitting in a silo doesn't help, and so interoperability is important as you think about connecting to other systems, providers, organizations, even technologies like remote patient monitoring. It all needs to be synced up, and that data needs to be flowing seamlessly. And all of that leads to actionable insights, personalized care, and again, the sky's the limit in terms of how you would utilize that information. So as you think about the different components, sorry, Greg, you wanted to chime in.
I would say with each of those points that you have on the apex there has its own family of representations of data, and that's kind of interesting. There's no standard that really unifies them. And so that's really the difficulty. There's some emerging standards that are promising to do that, but they're probably, 5 to 10 years off minimum. So that's the big challenge. It's the problem that we took on and you're trying to solve for our clients anyway.
Greg, I think you bring up an interesting point. Are you aware of, outside of these siloed attempts to introduce standards, do you know if there's any initiative, at least at a federal level or a CMS level, to be able to introduce a standard that they can sort of apply across the industry?
The only thing that comes to mind is the fire standard, which
Yeah.
is sponsored by HL7, but it's not really mandated by the government. And until it's sort of mandated for CMS, the rest of the healthcare industry won't sort of fall in line behind it. I think there've been some baby steps in that direction, mandating aspects of fire in the EHR standards, if I'm not mistaken, but it's still very, very early.
Yeah, and therein lies the challenge, right, in terms of putting this view together. And we'll get into a little bit of those details as we go into the webinar. I did want to cover the why behind this, right? Why is it helpful? And, when we think about patients or residents, especially in a skilled nursing facility or any sort of post-acute care setting, managing patients with multiple comorbidities is complex. We all know that, right? You have these patients coming in with intricate medical, functional, emotional needs, and it requires not just clinical expertise, but it also requires a lot of empathy. It requires collaboration, and it's recognizing that patient as an individual, and an individual with a full picture of who they are and where they've been and where they are today, right? And so, when we think about providing personalized, multidisciplinary care that all of these patients deserve and need at that stage of life, you want to make sure that the technology and the clinical teams are ready to deliver that. And that's where the need to put this information together is so much more important. So I'm going to go through this, and I'm jumping the gun here, but let's start with some of the medical complexity. Obviously, patients, a lot of these patients, there are numerous medications that increases the risk of drug interactions, side effects, non-adherence. And, a lot of these patients, they have multiple chronic conditions. They may have diabetes, hypertension, or COPD. And some of it might be very active, some of them might be passive, but you never know when there could be an escalation. Adding to all of that, you put acute illnesses or injuries on there and just makes everything just so much more worse, right? And so now you're not just looking at clinical intervention, but you're also looking at things like vigilance, things like making sure that the environment that they're in is adaptable to their conditions. And so when you think about all of that complexity coming in together, no wonder it's hard, right? And no wonder the likelihood of your clinical team missing something is so much higher. You obviously have your functional and cognitive challenges. Many of these patients, they face physical decline, they need tailored rehabilitation. Some of these patients, they need help with daily tasks. And so, I talked to a patient who was, who had dementia and, had a lot of needs where that impairment really caused them to stumble over themselves, and that led to a lot of issues that the clinical teams had to deal with. Falls is another constant concern with a lot of these patients, and so obviously things like physical therapy, adjusting their environment to the specific conditions, proactive fall risk management, all of that plays a big role. But overall, functional, cognitive, behavioral challenges really adds to the challenges. And of course, coordinating care, I'm not going to go through this in great detail, every one of these bullets, but coordinating the care, it hinges on good communication and good awareness, right? Patients thrive when physicians, nurses, therapists, dietitians, social workers, they all work together seamlessly. And a lot of times that's I would say in what we have seen, that's quite elusive, right? There are people working in silos and they're doing a great job, and they're probably operating at the highest end of their license. But as you think about that multidisciplinary collaborative effort, that is still something to be achieved. The other big piece is transition of care between hospital facilities or homes. That needs careful coordination with discharge planning and making sure that there is continuity and you avoid sort of setbacks. So all of that said, and again, I mentioned this before, I'm preaching to the choir, but caring for these patients is undeniably complex, but it's also deeply rewarding, and that's why we are in this business, and so are a lot of you guys. And so, we want to make sure that all of this can be made easy once you have a good, accurate picture of who that patient is. And that's a good starting point to pull this care together. Maybe I did this a little too much, Greg, but obviously I've spent a decent bit of time in some of these facilities and patients, and a huge acknowledgement in terms of how complex it is today, and really the uphill battle that these clinicians fight to give these patients the best care that they can. Okay, so let's talk about how we can start building this unified patient view. And let's talk about how AI is playing a role in that, right? So when we think about this unified patient view, it starts with aggregating the data, right? Aggregating the data from electronic health records, lab results, wearable devices. There are probably 4 or 5 other systems that I'm not thinking of right now. But it's really important to form that complete real-time picture of each patient. And this really allows a holistic perspective and really understanding, okay, what are the chronic conditions? What are the acute conditions, and especially the unresolved acute conditions? What are some of the social factors that plays a role in this patient? And how do you leverage that information to provide more effective and personalized care planning? And it starts with data integration. And it's not just clinical data, right? AI really helps integrating clinical data with critical behavioral data, functional data, cognitive data, social determinants of health, things like housing stability, family support, mental health. Do they have a care provider in their homes? And by weaving all of these factors into the patient record, it really helps sort of care planning that's designed not just in terms of treating the symptoms, but treating the entire person. Data aggregation, obviously a key challenge. And this is where, we've leveraged AI to sort of eliminate those silos and consolidate fragmented information into sort of a single accessible real-time, or if not near real-time, patient record. Leveraging insights for diagnosis and treatment, right? And so once you put that picture together, once you have a system of record in terms of all of that information coming in, you start identifying patterns in data, right? And patterns that not just in terms of that patient record, but also across a cohort of patients, and really supports things like clinical assessments. It helps from a coding standpoint for accurate reimbursement, also comes up with our enhances diagnostic and treatment strategies. And so every decision that is made needs to be informed by the most comprehensive and accurate information available. And all of that information needs to be evidence-based. And so we'll walk you through some of the work that we've done where we've extracted all of those insights, but then ultimately we put that in front of a clinician so that they can assess the patient for that condition, and they would basically accept or deny based on that assessment. And that are just critical steps towards putting that comprehensive view together. Finally, AI really helps in terms of proactive risk stratification and predictive analysis, right? It identifies high-risk patients, obviously, any potential complications, things like falls, infections, even something that's, from a timing perspective. We know that patients with a history of congestive heart failure run into issues during the holiday season and end up in the ER. And so putting a program around specifically those patients is hugely helpful. And by flagging those risks and forecasting those disease progressions, AI can really empower your teams to put that proactive, um, preventative programs in place that ultimately improves outcomes and boosts facility performance. So again, I can talk a lot about this. I guess one of the questions, Greg, that I wanted to bring you in here is, when we think about all of these aspects, especially around data integration and data aggregation, one of the fundamental challenges is harmonizing the data from disparate sources. And we'd like to believe that all of that data is identified, it's harmonized, all connects to a single unique identifier, and all we got to do is just band it all together. But reality is anything but. And so you've obviously done a ton of work around this space. How did you specifically overcome that challenge, especially around harmonizing data across disparate data sources?
Yeah, it's a really insipid problem. And like you said, you would think that it would have a pretty easy solution, even something uh, that's targeted for, let's say, Medicare patients. You would think everyone would have an MPI and that would be the master ID, but it's not present in all the records. It's entered incorrectly. There may be duplicate identifiers. It seems every platform that comes on, one of their goals is to have a new master patient identifier that can link everything. And then we find that those platforms have duplicate master patient identifiers. So it takes AI in itself, old-fashioned pattern matching and some looser techniques that are maybe a little bit noisy, but putting us in the wrong direction to find who are the patients who are potentially duplicates in the different systems. Because it would waste a lot of time. Two providers could be working in the same record and not realize it because they've pulled up record A instead of record B, and it's for the same patient. On that note, another insipid problem, which is not tied to patient identifiers necessarily, is trying to find the data source for what the end users are seeing and the platforms they're using. So their database is behind everything, but there may be tables that are, in some cases, decades old that look like they should be containing the data that the end user is looking at, but they don't. And so that's another problem. So it takes just to identify the patient in itself is a big goal of some of the work that we do so that we can proceed and make sure that we have a coherent view of what's going on.
Yeah, no, I think that's interesting. And, I also wonder the role that each of the players play and uh, where they sit. Some of those roles are compromised. And here's what I mean by that, which is, so if I'm a provider of a remote patient monitoring device, right? I can give you my data, but I cannot necessarily work with other vendors who are providing their own data. So, and so that would be the same thing for lab. That would be the same thing for EHRs. That'd be the same thing for a medication management system. And so it really requires somebody who's sort of agnostic to all of these providers to then pull them together to go, okay, here's the common view that we'll need to develop to put that together, because that's ultimately what the providers need, right? And that's really what is of use to them from a care planning perspective.
Yeah. And some of the things that you end up having to come up with are almost brute force. They're a case of integrating patient monitors from different sources. There's no standard interface. There's no standard data format. In some cases, you have to resort to character recognition of the screen to determine what's going on one particular device.
Mhm.
So yeah, there's definitely challenges there.
All right, so let's dig further in. And so when we think about creating these unified patient data systems, there is a ton of considerations involved. And I would say this is just a very short list, and this list could go like 5 times long. Starts with the unified data model, right, which consolidates information from various sources. And some of the complexities comes from the fact that, as Greg mentioned, some of these databases could be decades old. There are multiple different kinds of databases, how they're linked to a common identifier, which is really the next point, which is data matching. All of that is different, and it requires somebody to pull all of that information together because ultimately you want to make sure that you have confidence behind that data. And so from a data matching perspective, concepts like, as I had mentioned, the master patient index or a probabilistic matching algorithm really ensures that the identity or the unification identifier really is something that's of high confidence, and we know that we're talking about the same patient. The longitudinal view is also essential, really providing a single seamless interface that displays a patient's complete historical record, right? And obviously the look back, how far back you go and where it's relevant, it's really dependent. But sometimes, we've noticed over and over again, chronic conditions drop off, right? Just because they didn't have an escalation of COPD last year doesn't mean they don't have COPD, right? And so you want to make sure that that longitudinal record is accurate so that you can uncover conditions that the patient still has, except it's being managed well, but you don't want to sit on that fact. You want to make sure that you're still providing care planning around that chronic condition. All of these models and matching algorithms and views, all of that's important, but ultimately the insights that come out of this really needs to be weighed in by the clinician. And so as we think about these algorithms, as we think about these insights, you want to make sure that the clinicians who are in front of the patient, they're the ones validating these insights or invalidating. You want to have both. And that feedback needs to be integrated so it's a full cycle. It's a full continuous loop that drives continuous learning of the algorithm, right? So all of that really enables a smarter, more cohesive approach to patient care. And again, I know, Greg, I'm touching just a very, very small subset of the world that you've been in. As you think about all of these sources, I'm also wondering, there's this component of structured versus unstructured, right? And yes, life would be so much easier if everything was structured, everything was in nice, neat databases that were appropriately marked and identified. But we know that that's not reality. So as you think about data residing in structured and unstructured sources, I know this is the world that you had to deal with. How did you and the team sort of make sense out of the data, especially the unstructured data, and putting that into this ecosystem of this unified view?
Yeah, one of the things I was going to say is there's an art behind trying to develop a AI-based system. AI is kind of a catch-all term, but there are different types of AI. And so you need to know which tool to pull out of the toolbox at different times. So take unstructured data as an example. When you're trying to pull meaning out of some unstructured data, maybe a progress note, you always have to weigh between using kind of a rules-based tool that's doing simple text matching versus something a little more robust, like what's called a large language model that's performing a descriptive AI task. It's trying to extract data and give you specific tokens coming out of that. So there's a challenge in determining what to use when, and it really is almost on case by case. You would be quite surprised at the percentage of data that is unstructured, or I would say ends up being unstructured. There's a case I'm aware of where we'll have one system that has structured data, but then to port that structured data over to another system, they will print it out in a PDF, and then the PDF gets sent to the other system. So it ends up being unstructured data, even though it's structured at the source. So these are the kinds of things that need to be dealt with. And then beyond that, the other kinds of AI that you could think about, I think some of the things you touched on would use one or more of these would be predictive AI, where you're looking on past trends and trying to predict what the future is going to be. And then the next step in that is prescriptive AI. You talked about proactive recommendations, where not only are you forecasting what appears about to be happening, but also which direction you can push it. So that's a challenge, and so you need to have people on your team who are familiar with all of these, either group who specializes in each area, or someone who has a big view of the overall field.
Mhm. I know this challenge of extracting data from PDFs keeps coming back. I was actually at a conference, an AI conference, a few months back, and actually saw a few different vendors investing some of their development resources to solve this challenge in terms of reading PDFs and translating that data with a relative high confidence interval into structured notes. But any developments in that space, Greg, that you're seeing that you're excited about?
Um, that's a problem that has been in the process of being solved, I think, for maybe 10, 15 years, going
Oh,
back to when
yes.
Acton came up with the standard. Um, yeah, I think you still get thwarted from time to time with the case of someone taking structured data and destructuring it
Mhm.
and not expecting to see what you see. And PDF files do have different fields that you can kind of key in on as things that that are of interest. But then as soon as you move on to something that's sourced from a different platform, you almost have to reinvent the wheel because
Yeah.
it's got a completely different set of fields to it. So just
Mhm.
even recognizing, is this a valid field or not to extract it, that in itself is a challenge.
Yeah. Yeah. In my simplistic world, especially when I think about a brand new resident coming in and getting admitted, and the mountain of paperwork that they bring with them, a lot of them actual paper. I wish I wish there was a machine where you would just dump all that in, and the algorithm basically scans it and puts everything in a structured note, and the MDS
Yeah.
coordinator is off to the races.
Yeah, and the irony is there was some system that had that data structured that printed it out into a document that will be
Right.
handed off to the provider. And what will they do? They'll scan it into a PDF. And then they'll insert the PDF into their system. I understand. I was a customer of some of those systems recently when I had some spine surgery, so
Yeah.
I saw the process firsthand.
Yeah. Yeah. No, it's definitely not for the faint of heart. So speaking of that, obviously Greg speaking out a lot out of his experience, and some of that experience has come from the different case studies that we've executed over the last few years. I'd like to talk specifically about one. We had a client. They owned over 100 skilled nursing facilities across multiple states, and they came to us essentially saying, one, they didn't have the confidence that all of their patients were appropriately risk adjusted, and that their care planning could use some help in terms of having a fuller view of the patient. And they were also were not able to get in front of all of the conditions, and that led to a lot of reactive care, uh, care delivery as against proactive. And so this team, obviously, Greg was at the heart of that, executed a 3-year look back, um, obviously extracted a lot of clinical and non-clinical information. They did have this client, they did have a Medicare Advantage and also an ACO, not reflected here. And all of the solutions of the algorithm that the team worked so hard in creating, all of that was integrated into the EMR. And the most important thing was to be able to integrate the clinician feedback loop into this, right? Which is everything that we would surface was assessed by the clinician. and was blessed by the clinician, or discarded by the clinician. And so everything was evidence-based, everything was clinician approved, and all of that feedback was cycled back into the algorithm, so the algorithm gets better and better. And this also helped us not just in terms of surfacing what was in historical records, but the team was also able to do a cohort analysis so that we could understand that patients with a similar demographic, with a similar profile of chronic conditions could also exhibit risks for another condition. And we would surface that in, and the clinician would go in and get in front of that. And that feedback was also very instrumental in getting ahead of these patient conditions, and also really impact our, executing a comprehensive care planning process. And so that said, obviously it required a tremendous amount of work and figuring out. And, I remember the team going through many agonizing days, distilling, CMS rules and codifying them into something that the development team can run with. Obviously, Greg, you were at the heart of this. I'm going to ask you to chime in here again. When you think about how the team executed, I want you to kind of step back and go, hey, what were some of the skill sets that were needed to execute in this space? And, it's easy to think that, oh, you plug in and drop a technical or a development team and ask them to code something, and that solves all these problems. But I know we were getting into spaces that were way beyond technical. And so what are your thoughts in terms of, ideally, what are the skill sets that's needed on a team to be able to execute a challenge like that?
Yeah, I mean, there's this no man's land of regulations that is extremely detailed. And you mentioned, basically coding the regulation, which isn't very far from the truth. So the case in that you're discussing at the moment, as you said, this client had skilled nursing facilities. They had their own Medicare Advantage plan. Not only that, a special kind of Medicare Advantage plan, a special needs plan that has its own rules and regulations. And then they were just launching an ACO. I think those are the three main things that we had to grapple with. And so if you look in the facility context, the things that we needed to be familiar with were the MDS assessment instrument, the RAI, which spells out in hundreds of pages what each field in the MDS is meant to represent, how it's supposed to be represented. The quality measurement, because one of the things that we need to track is not only on the reimbursement side, which is derived from the MDS, but also on the quality measure side. And so that has its own manual. Each quality measure, and there, are a couple dozen of them, long stay, short stay. They have rules for including a patient or not including a patient in those that will be counted in the facility. There's special rules for risk adjusting the facility based on the overall patient picture. These very, very complex things that are looking at specific fields of the RAI, of the MDS, and basically need to be coded, need to be hard coded. There's no way you can just go to a lookup table. Each one of the QMs is represented in a completely different way. Each facility has a 5-star rating. The 5-star manual in itself has its own rules for how points are awarded based on the quality measure scores and combined with claims-based measures. So that's the facility complex. And we can talk about the payer complex, the special needs plan. There are audit protocols that come out every year for determining has the patient had an adequate number of health risk assessments, have they had their risk stratification done, et cetera. The plan has its own model of care, which becomes essentially a regulation in itself. And then there are these updates that come periodically from Medicare that have appendices that have the rules for risk adjustment, assigning risk adjustment factors to specifically ICD-10 codes. All that needs to be tracked. Someone needs to keep on top of that and understand when an update comes out. Some of the updates are regular, they're at the end of the year. Some of them are sort of ad hoc. And then you mentioned ACO, that's a relatively new challenge. There's, I think, a private company that had the job of coming up with the standards of basically outsourced to do that. There may be 5 to 7 manuals that have to be consulted for the ACO. ACOs stratify risk and deal with risk in a slightly different way than SNPs, special needs plans. So these are, thousands of page, and you can't miss details. You can't just run this through, the LLM of the day and get a synopsis and then, okay, here's what the developers need to do. Someone actually needs to read through those pages and make sure that you're not missing a critical detail. Because if you misinterpret what needs to be done, you risk some on the risk reimbursement. You don't put the patient in the right PDPM case mix group, and or you end up not awarding enough quality incentive points, Medicaid, to the facility. And so there's serious financial consequences of not doing that correctly, and that in turn leads to lower resources for patient care.
Yeah.
So yeah, it's, as you said, it's not just a case of finding a group of very talented developers and giving them, here's what you have to code. You have to have someone who can kind of bridge the coding side with the regulation side and turn regulations into code.
Yeah.
Sounds like maybe our next application, our next AI
Yeah.
application.
That's right. And I'll tell you this, I'll take that one step further, which is obviously you need to translate all of those rules that needs to be codified, and then you build a solution around it. But there is an element of design and process simplification that comes into this as well, which is, hey, let's say you've codified it, you've developed the product, but now you got to have your clinicians actually use it, right? And so that experience is also supremely important, recognizing the fact that there's very little hours in the day and everybody is stretched to their limits, these clinicians, and you want to make sure that that user experience is not detriment to their day in the life of, and that it's as seamless as possible. It's baked into their workflow, and they're actually able to use the solution as a way to help and be good at what they do. And that's another skill set that we've deployed to be able to solve this challenge.
It's got to be engaging enough that they are eager to use the tool,
Yeah,
to see what's the development in that facility overnight. So
yeah,
that's a
yeah,
good point.
understand. All right. No, I think we've covered that to a great degree. And again, happy to chat about this case study more. So please reach out if you guys have more questions. I know we're running out of time, and so I did want to start the wrap-up process, and by essentially summarizing just some of the key elements from just this webinar. And it starts with obviously AI's role in building this this unified comprehensive view of the patient. It really starts with that full picture. So as you think about leveraging AI to consolidate data from multiple sources, you're really providing that holistic view to clinicians so that they can drive personalized care, they can drive sort of seamless teamwork, and really proactive risk management that is so needed for these patients in these facilities. And why do they need that? It is really to manage that complexity, and it's in recognition of the fact that that complexity will exist and it's not going away. It probably might get more complex. And so, making sure that we're providing a solution that simplifies that chaos of multidisciplinary care by organizing data, tackling some of these medical and cognitive challenges, enhancing care coordination, all of that is rolled into one to be able to simplify that process. The actual building of the 360-degree patient profile starts with that unified data with standardized models. We talked about patient matching, longitudinal views. Obviously, we talked also about how that full cycle clinician feedback loop is also super important. because the algorithms that you create will need to get smarter, right? And it gets smarter as you put in that feedback into the process. And obviously keeping the clinician at the heart of all of this, right? Because we mentioned this, which is it needs to be evidence-based, right? It's not something that the AI is spitting out and somebody's blindly accepting it. You want the clinician at the heart of it so that they can validate those suggestions and update your systems accordingly. And the next one is, okay, I jumped the gun here, but again, it's the evidence-based insights and predictive care. And the only thing I would highlight there is the goal is to get to prevention, to get ahead of the problem, not provide care after the problem. And so if we can create a technology ecosystem and leverage AI to be able to get ahead of that problem, that's really the future of patient care, right? And I make that as a bold statement but that's really where patient care is going, should be going. And this is one small way where we are advancing that effort. Any thoughts on this, Greg, before I move on?
I think you captured everything. Yeah, I don't want to take us down a down a hole somewhere, but I think we've covered everything that's important.
Yeah. All right. So when we think about this webinar series, this was a series of 5 webinars. The first one happened in October. Actually, I wasn't off. It was about a month and a half back. Maybe closing in on 2 months. Obviously, this one was around the evidence-based 360-degree profile. The next one is going to be in January, and I'm excited to talk about that. And that's really all about the workflow. So, all you MDS coordinators, nurses, clinicians who live and die by their workflows on a day-to-day basis, we want to talk about how we can leverage technology to ultimately just empower your staff to make smarter data-driven decisions. And we say that with a lot of experience because that's what we've been doing over the past several years, which is that workflow needs to be front and center, right? You don't want to create a solution or an analytic or an insight that disrupts a clinician's workflow, right? Clinicians are clinicians because they're good at something. You want to let them be good at that and operate at the highest end of their license, and really focus on patient care. And we've run into a dime a dozen products that seem promising, but it's disruptive to that workflow. It's one more thing that they have to deal with, and it almost derails a lot of the clinicians. And so we'll talk a lot about how we can bake these solutions seamlessly into the workflow so that you're really empowering the staff and not deterring them from what they need to do. And we've got 2 more, one in February and the other one in March, that we will go into from a webinar standpoint. All of these webinars, I do want to reiterate, are recorded, and the slides are provided to all of the attendees. But that said, I am sure you have questions or comments or opinions. Please reach out. We'd love to talk to you all. And so you can use that QR code to set up a meeting. And I think that comes to me, but if you want to talk to Greg specifically, we can definitely get that coordinated. All right, Q&A, looks like we are at the top of the hour. So we do have a few questions, it looks like. However, I think we're gonna reach out to you all individually to address those questions. This is a little bit of my profile, and you can obviously click on that to schedule a meeting. And I also put Bob's information in there. Bob's our CEO, super passionate about this topic and about the space. And so feel free to reach out to him as well. All that said, I do want to say thank you for joining us. I know we went a little over, but there's really a lot of learnings that we wanted to distill down into the short webinar, which is not often easy to do. But I also want to spend just a quick minute to thank Greg. Greg, thanks for jumping on with me, so that way the audience doesn't have to hear me the entire hour. But really, thanks for chiming in and sharing your experiences. There's a lot in there as well, and I'm sure there's a lot more people who can benefit from that experience. So thanks for sharing. All right. Well, I think this brings us to the end of the webinar. Thank you, everybody, and have a great rest of the day.